Welcome to all the attendees to this afternoon's monthly COVID-19 webinar hosted by the Department of Medicine and Project ECHO. To start off with, we're going to be having an update on the epidemiology of COVID-19 in the Western Cape. That's going to be given by Hannah Hussey. Hannah is a registrar in public health at UCT and has been working in the Western Cape Data Centre since the start of the epidemic. And I've really asked, given the full program today, for Hannah just to keep this as a short update, and I'm very appreciative of Hannah for sharing with us the latest data from the Western Cape Data Centre. So over to you, Hannah.
Great. Thank you so much, Prof. And good afternoon to everyone. So can everyone see the presentation?
Yeah, we're seeing it, just not in full screen mode. There, no, yeah, there we go.
Great. So I'm going to be giving a very brief epidemiology update now. Next slide, please. So unfortunately, the case numbers have started to increase again. Oh, sorry, we just skipped ahead. Can you go one slide back, please? So using the 7-day moving average, we've seen around 320 cases being diagnosed each day. This has been driven mostly by the private sector cases. That's the light brown in the bar graph. Our reproductive number is been on a steady upward trend, and it's now sitting at just below 1.25 for the province. And although it hasn't officially been declared, it does appear that a third wave is now imminent. The threshold we're using is 30% of the previous peak. And so using wave 1 as our reference, we need just over 400 new cases each day to get there. And that should happen in the next week or so. Next slide, please. And then if we just take a little bit more detailed look at where the cases are coming from, you can see that the case numbers are increasing across the province. And all areas are showing an increase. The only exceptions being Khayelitsha in the metro and Central Karoo in rural. And then just to take a step back and look at the national picture, the graph on the above is from the South African COVID-19 Modelling Consortium. And there you can see that most provinces are experiencing an uptick in cases at the moment, and that Free State, Northwest and Northern Cape have crossed the threshold and are in a new wave at the moment. Next slide, please. And then just to touch very briefly on the other metrics that we're watching. So the proportion positive in the province is also increasing. In April, we had a positivity rate of around 5%. That's now crept upwards, was around 10% last week and is currently sitting around 8.5% at the moment. The NHLS has also reported that the median cycle threshold values for the province has decreased. And this drop in CT values indicates an increase at the population level of the viral load. And tends to herald the start of a new wave. With regards to admissions, we've seen an increase in admission numbers as well, around 40 new admissions each day, and there's been a small associated increase in bulk oxygen consumption as well. Deaths, however, have not yet started to increase. The graph on the top looks at the COVID-19 associated deaths for the province. These are the confirmed COVID-19 deaths. And that's remained relatively stable at around 5 per day. This is corroborated by data from the MRC, which has been looking at weekly excess deaths across the country. And they found that the excess deaths in the Western Cape have not yet exceeded the upper prediction bound. And so in summary, case numbers are increasing, proportion positive is increasing, admissions are starting to increase, and a third wave is imminent. So apologies for being the bearer of such bad news, and that's all from me. Thank you.
Thank you very much, Hannah, for that high-level overview, and it forms a very good backdrop to our discussion today. So as Mark said, our thinking was that as South Africa now appears to be preparing for a third wave of COVID infections entering the health service, and we are seeing a substantial rise in hospitalization in certain provinces, it would be useful for us to review key aspects of COVID management. And so we've got 8 speakers today, each experts in their particular fields, who can provide us with high-level summaries. I've asked if they can each keep their talk to 7 minutes, just providing information on the evidence that we've gathered to date and the experience that we've had of treating COVID, firstly at Groote Schuur, and then what evidence has emerged in the literature over the last year or so regarding the treatment of COVID-19. So to start off with, Sipho Dlamini, who's an infectious diseases physician at Groote Schuur and UCT, is going to deal with the issue of anti-inflammatories and anti-infectives in the treatment of COVID-19.
Thank you, Graham, and good afternoon, colleagues. I hope you can see my screen. So I'll be covering anti-inflammatories and anti-infectives for COVID-19. I think just to remind everybody, of course, this is a multi-systemic disease, and many organ systems can be involved, and obviously with that we've got this biphasic episode of viral replication and inflammation, which then is a challenge in terms of how do we treat it. And you can just see in the slide that earlier in the stage of infection, you're really dealing with the virus, and then at some point the inflammatory cascade kicks in, and we are 18 months down the line. We've learned some things about how to treat this infection, but there's still lots to learn. And some of these therapeutics you'll see here, obviously, because of the trials that have come out, have changed in terms of the use of, say, colchicine or corticosteroids or doxycycline and azithromycin, which I'll share with you some of the data. But I think what's critically is just recognizing that although we do understand some of the pathophysiology and the events that happen during infection, there's still that we don't know. And the key question is, how do these therapeutics help in attenuating some of the negative consequences of COVID-19? So the first issue I want to cover is the issue of whether patients presenting to hospital with what is COVID-19 have bacterial co-infection. What we saw in the last year is there was certainly quite an overuse of antibiotics when patients were presenting with this pneumonic illness because there was a concern of bacterial co-infection. Though limited, the data is suggesting that co-infection with COVID-19 is very limited or very small, with studies showing that as it being as low as 4% in terms of patients admitted to hospital with co-infection with bacterial infections. And certainly there's a recognition that as patients have a prolonged stay, secondary bacterial infections is certainly increased. But the important thing is that though limited, the data suggests that patients who present to hospital with COVID-19 do not have bacterial co-infection. And a number of jurisdictions are advising a more restrictive use of antimicrobials for patients who present to hospital with either proven or what looks like COVID-19. So I think it's quite important to note this, because we certainly in the first and also in the second wave saw probably an overuse of antimicrobials when patients were coming in with what looked like and was proven to be COVID-19. So certainly, I think there's a recognition that co-infection with bacterial infection is quite low, and often if the diagnosis looks like it's COVID-19, antimicrobials are probably not necessary in that context. The issue of antiviral, I think this audience will know that a number of therapeutics have been tried to look at at their antiviral ability. And the one that really stands out and shown in randomized controlled trials through Solidarity and the ACTA trial is remdesivir. And when you look at the data, really just to say that the data suggests that people who present with COVID-19 is certainly earlier in the course of illness, less than 10 days, and would be requiring supplemental oxygen. There seems to be a role for remdesivir in shortening recovery and reduction in the risk of progression. However, the cost of the drug is something to take note of, and one of the provisos is that it may be a drug you can use where it seems that it may be cost effective in certain healthcare settings. So certainly, if you look at the WHO guidance, they don't recommend remdesivir, and one of the factors I'm sure is because of the cost issue. And the other thing to note with remdesivir is that if you've got mild or moderate to severe COVID and not requiring respiratory support, the evidence suggests that remdesivir does not offer any significant benefit. So I encourage colleagues to look at those papers that have looked at this issue of remdesivir and where it fits in treatment. Anti-inflammatories is another key pathway in the pathophysiology of this disease, and dexamethasone certainly is one from the recovery trial shown that it is beneficial in hospitalized patients with COVID-19, and certainly giving you lower 28-day mortality, and the evidence suggests that those patients requiring oxygen certainly get the most benefit, and those who are not requiring oxygen will probably not benefit from this therapy. And this slide or picture here just shows you all the trials in which dexamethasone or steroids have been used. And overall, I think the suggestion is that the intervention of steroids is favorable, and patients certainly benefit from a mortality perspective. And this paper, which was released, I think, in the Journal of American, JAMA, is a meta-analysis of all the trials that had looked at this issue of steroids in patients who have been hospitalized with COVID-19. The next issue, of course, is when you look at these anti-inflammatories, what else can you use and shown to be beneficial? Certainly, there have been a number of drugs. So tolizumab has been looked at, and again, one drug showing that there are improved survival and clinical outcomes in those who have got hypoxia and systemic inflammation in COVID-19. Colchicine, the results are not encouraging, and probably a therapy that probably wouldn't be useful as an anti-inflammatory for patients with COVID-19. However, of course, we're waiting for the peer-reviewed paper to confirm this. So this is just my last slide. So when you look at these therapies, where are we? So I think the evidence is quite clear that glucocorticoids are quite established as a mode of therapy, remdesivir, and then of course, when you're looking at anti-inflammatories, interleukin-6 receptor antagonists certainly play a role in therapy for patients. It looks like where these therapies work is probably all in combination rather than just a single entity. And I'm not going to talk about anticoagulation because that's going to be covered by my colleague. But the other thing just to say is that the JAK inhibitors seem to also offer some benefit for patients with COVID-19, and certainly I showed you a paper where these have been used in combination with remdesivir, and that seems to be promising. So, colleagues, these are just a few snapshots of where we are with the therapies for COVID-19. Obviously, some of these therapies are limited in their use in the state sector because of cost, but I think this is where the evidence is, and I think it's quite clear that the therapies that have proven mortality benefits, certainly the steroids, remdesivir certainly earlier on, are key important interventions. Thanks, Graham.
Thanks very much, Sipa, for that overview of a very big topic in just a few minutes. I really appreciate that. Our next speaker is going to be Sean Wasserman. Sean is also an infectious diseases physician, and Sean's going to look at issues around the use of anticoagulants in patients with COVID-19.
Thanks, Graham. Hi, everyone. Yes, my microphone's unmuted. You can see my screen. So as the title suggests, I'm only going to deal with the issue of anticoagulation in patients who are inpatients, because the data for outpatients is pretty scarce. And also, although there isn't a lot of consensus on this issue in general, there is consensus that with current knowledge, the use of anticoagulation in outpatients is not recommended of prophylaxis or therapy. So just to provide some background, I think Sipa's already kind of covered this. Thromboinflammation is now well established to be a feature of COVID. It's a consequence of poorly controlled viral replication in a subgroup of patients who progress to inflammatory disease. The viral replication leads to, as you can see in this figure here, cell death, apoptosis in pneumocytes and in the endothelium, releasing platelet activation factors and activation of platelets and coagulation factors. There are other factors associated with illness in COVID that can contribute to developing these complications. And the complications I think we're all familiar with. I've just shown some pictures here from patients that we saw in the first wave with massive central pulmonary emboli. These are two separate patients. But also on a microvascular level, thrombosis is common. And in postmortem studies, in people that die with COVID, it's almost universal. And you can see pictures here demonstrating multiple microthrombi in the alveoli very clearly, but also extravasation of red blood cells and bleeding into the alveolar space, which you can imagine could be a consequence and a complication, a terrible consequence of anticoagulation. If it's not beneficial, it could cause harm like that. So in addition to recognizing this common clinical complication of COVID, we've also seen that D-dimers, which are commonly elevated in people with severe COVID, are associated with worse outcomes, and they may be predictive of venous thromboembolic disease. And this led to a lot of enthusiasm early on to use anticoagulation quite aggressively to try and prevent these complications, with the thinking that this might actually reduce morbidity. And in early uncontrolled studies or controlled studies that were not randomized, there was a suggestion, an inconsistent suggestion of benefit from anticoagulation in severe COVID. And this kind of led to the question and leads to the question about whether thrombosis is really just a marker of severe illness and kind of goes along for the ride, or is an independent contributor to mortality. And in the latter case, if that's true, does it require prevention or treatment? And really the only way to address this is with well-conducted randomized controlled trials. And I'm going to speak to you briefly about 3 that have been reported. One of them has been published, that really has started to influence this field and provide some clarity about how to use these drugs in COVID. So the first trial, which is actually a group of 3 protocols that became harmonized to try and address this question, is a group of 3 trials that were sponsored by the NIH. And the trials were done in the UK, the US, Canada, and Brazil. They were all multi-platform, open-label trials. They used adaptive Bayesian designs, which we can talk about later. The intervention in all 3 of these trials was to randomize people to either receive therapeutic anticoagulation with heparin or to receive prophylactic doses of heparin, which has always been the standard of care. And actually, groups in this trial received varying doses of prophylaxis. So some of them received enhanced doses, which we can also talk about later. But the intervention was therapeutic anticoagulation. The primary outcome in these trials was an ordinal scale, which combined in-hospital mortality, so death, which they assigned a score of -1, so that's obviously pretty bad and the worst score. And then days free of requiring organ support up to day 21. So the more days free of organ support, obviously the better the outcome. Key secondary outcomes included major bleeding, major thrombotic events, and death on its own. And there were 4 groups in this trial. One was a severe or critically ill group of patients that were defined as being requiring respiratory organ support. And I've highlighted here high flow nasal oxygen, which is what we use often, non-invasive ventilation, mechanical ventilation, or cardiovascular support with inotropes. The second group was a moderately ill group of patients who were hospitalized but did not require ICU admission or organ support, as I've described. And then that group was further stratified into 2 D-dimer strata. And this was all pre-specified. So one group with a very high D-dimer of more than 2 times the upper limit of normal, another group with a low D-dimer, less than 2 times the upper limit of normal. And these 4 groups were independently analyzed. And you'll see in the moderate group also combined analyzed. So I'm going to start with the severe cohort, which randomized, as you can see here, more than 1,000 patients. And you can immediately see that there were fewer organ support-free days in the therapeutic anticoagulation arm compared to the usual case, suggesting that it's actually worse. And when that was analyzed as a proportional odds ratio, the proportional odds ratio of these organ support-free days was less than 1, suggesting inferiority. And actually, when this was simulated using a Bayesian approach, it reached a pre-specified threshold of actually a high probability of inferiority. So for the primary outcome, therapeutic anticoagulation in the severe group of patients appears to be worse. And when you look at mortality, there was no difference between the 2 groups. And the primary outcome is well demonstrated here on this figure, where blue indicates better outcomes, so more organ support-free days, and red indicates either death or less organ support-free days. And you can see that therapeutic anticoagulation actually has a little bit more red. And this was despite actually fewer thrombotic events with the use of anticoagulation, but more major bleeding. And so I think the message in this group is clear, which I'll summarize later. What about the moderately ill group of patients? Well, the numbers, so they randomized more than 2,000 people, and the numbers weren't reported in this preprint. It hasn't been peer reviewed yet, and hopefully this will be picked up in peer review. But the odds ratio for the primary outcome did suggest some benefit with therapeutic anticoagulation in this mild group, and the pre-specified margin for superiority was met, or threshold for superiority was met. Most patients, so there's a high probability that this is true. But the effect actually became more diluted if you look at the pre-specified subgroups of the high D-dimer versus low D-dimer. So in the high D-dimer group, it touched 1, and in the low D-dimer group, the effect disappeared. It became no longer significant. And so there doesn't appear to be benefits in this low D-dimer group, and there might not be benefits in this high D-dimer group either. Again, the difference in survival to hospital discharge was no different between these 2 patients, same as in the severe group. And you can see here for the primary outcome that really there isn't much between them. If there is an effect, the effect is very small with therapeutic anticoagulation, slightly less red, slightly more blue in that group. In this group, in contrast to the severe group, there wasn't a real difference in major thrombotic events. It was significant, but 8 versus 9.9 is not major. But there was double the risk of major bleeding, which is something to consider. And then just quickly, 2 other trials. One on the left, which is published, was called the Inspiration trial. That was done in Iran, and it included people with COVID pneumonia who were admitted to the ICU, but actually quite a high proportion of them were just on face mask oxygen. Their intervention was intermediate dose anticoagulation, and it was randomized 1-to-1 versus standard dose prophylaxis. Their primary outcome was thrombosis, a composite of thrombosis requiring ECMO or death. And they found absolutely no difference between intermediate versus standard dose prophylactic anticoagulation, but a much higher rate of major bleeding in the intermediate anticoagulation group. And you can see here that on these survival curves, the intermediate dose enoxaparin actually even might have looked a bit worse. And then finally, in results reported from this ACTION trial at a cardiology conference a couple of weeks ago, they randomized 615 patients in Brazil, and these were inpatients who had COVID pneumonia and an elevated D-dimer. You can see the distribution of oxygen requirements here. So 60% of them were on face mask oxygen and much fewer on high flow or ventilation. And those patients who they defined as stable, so basically outside of ICU, got rivaroxaban, which is a direct-acting oral anticoagulant, and those in ICU got heparin anticoagulation. Their primary outcome was a composite of mortality and a reduction in hospitalization or oxygen use. And you can see here that in the blue, in the prophylactic standard group, those patients actually did better compared to those receiving therapeutic anticoagulation. So there was no improvement in clinical outcomes for this primary outcome. There was double the rate of major bleeding in the anticoagulation group, and there was a higher mortality. It wasn't significant, but it seemed substantially higher. So the conclusions from these trials in the severe COVID pneumonia patients. So
we're going to have to move along quite soon. So
okay, final slide. I'll move to. So based on this, my suggested practice is in patients requiring high flow oxygen, non-invasive ventilation, or mechanical ventilation should get standard heparin prophylaxis. And this really is in contrast to what a lot of people have been practicing. So that's a flat dose of 40 daily of low molecular weight heparin. Patients who are on face mask oxygen and are at lower risk, so low D-dimers, should also get the standard dose. And then for those on face mask oxygen who might be at higher risk of thrombosis, so high D-dimers, we can consider therapeutic anticoagulation. Thank you very much.
Great. Thanks very much, Sean, and for that overview, as well as your recommendation based on your thorough review of the literature. So next, we're going to move along to 3 talks now that are really going to deal with broadly the management of respiratory failure in patients with COVID-19. And first, Greg Caligaro, who's a pulmonologist at UCT and Groote Schuur, is going to discuss managing respiratory failure outside the ICU. Thanks, Greg.
Thanks for having me, Graham. In the interest of time, I'm going to move straight to the meat of it. So offering respiratory support to patients with severe hypoxemic respiratory failure outside the ICU has some logistical and equipment-related requirements. Firstly, we've practiced cohorting these patients in designated high care wards, and that has been because of concentrating expertise as well as because of the PPE requirements. Really nice to have is if you've got 2 oxygen ports per bed space and 3 electrical plugs. The reason for the 2 oxygen plugs is to be able to move between a ventilator and high flow if you're intubating patients. In order to upscale this effort, we've tried to stick away from increasing nursing needs. So we haven't approached high care nursing ratios, but what's been absolutely critical and it's been a very important part of our service has been input from clinical technologists to maintain the equipment and to keep the system operational. A minimum requirement for monitoring is co-oximetry, although ECG monitoring and full monitoring can be used for some of the sicker patients like those with DKA. And then lastly, you need a good backup service if things go wrong with non-invasive support. So if not an intubation team, at least a well-trained group of doctors that are immediately available should things worsen. Not without its perils is maintaining the oxygen supply to be able to provide respiratory support outside the ICU at scale. And we've had experience with both problems in total oxygen supply, which has gone up tenfold during the COVID waves, as well as very local requirements in terms of the reticulation of the pipes that deliver oxygen to the individual bed spaces, which may become limiting when you're running lots of high flow machines in series. Really, the provision of respiratory care outside of the ICU boils down to the provision of oxygen. And central to this is the stepwise escalation algorithm for oxygen therapy, or the so-called oxygen ladder. And this involves assessing the patient's respiratory rate as well as peripheral saturation, and then escalating their oxygen requirement from either nasal cannulae to a face mask to a non-rebreather, then to some form of non-invasive support, of which we have found high-flow nasal to be the easiest to implement. And then ultimately, if none of those work, or if the patient's mental state or clinical condition is deteriorating, for urgent review for candidacy for ICU with a view to intubation and mechanical ventilation. There isn't really enough time to discuss all the different non-invasive measures. We've chosen high flow for many reasons. We feel that it's scalable. It doesn't require a lot more in terms of nursing supervision. Patients can often be in charge of their own interface. It's not something that can come off or leak. It allows the patient to eat and drink, and it does provide a very reliable high FiO2 with heat and humidification, which is generally well tolerated. How do we use high flow practically? Well, we start at a flow rate of around 40 liters per minute and then titrate the FiO2 upwards to maintain saturations of about 92%. Remember that the FiO2 delivered by the machine is a composite of the flow rate at the wall as well as the flow rate set by the machine. And then if that is insufficient, we increase the flow rate at about 10 liters per minute increments if the respiratory rate fails to improve, bearing in mind that it's the high flow rate which counteracts the high minute ventilation in very sick patients and allows for the washout of dead space and the delivery of a very predictable FiO2. As I said, it's got an advantage, and the nasal interface of high flow has got an advantage because patients can also wear a face mask, which is good for preventing droplet spread of infection, but also allows them to eat and drink without taking up a very tight-fitting mask, which may be difficult, painful, or uncomfortable to wear. Assessing whether high flow is failing is really something that is largely a clinical judgment, but there are some tools that you can use to help you. This is a well-validated score called the ROC score, which uses the SF ratio, or the ratio of your SATs to your FiO2, and divides that by your respiratory rate. And in work from our group, we've shown that a ROC score measured at 6 hours after high flow initiation has got sensitivity and specificity cutoffs for predicting failure or success. Now, as you can see in this graph, there's a considerable degree of overlap over the middle values, but a ROC score of less than 2.2 predicts strongly for the need for intubation, whereas a ROC score at 6 hours of more than 3.7 quite comfortably represents a high likelihood of high flow success. So we propose this algorithm for how to use non-invasive respiratory support in patients who are not saturating well on non-rebreather face masks and who still have an increased work of breathing. An important exclusion is patients who are hypotensive or who have an altered mental state, which shouldn't be considered for non-invasive forms of respiratory support and should be prioritized for mechanical ventilation should they be ICU candidates. If these requirements are not met and your patient is awake and hemodynamically stable, then you can trial high flow with vigilant monitoring. Patients should be evaluated in terms of their respiratory distress as well as their ROC score at 4 to 6 hourly intervals. And those whose ROCs is less than 2.2 should be considered for intubation, whereas those who have a ROC score of more than 3.7 are likely to succeed. And obviously the group in the middle might need closer attention. I don't really want to talk about other forms of non-invasive support, but it can be considered. BiPAP or CPAP is a valuable measure, and we felt that it wasn't really scalable because it requires a lot of extra nursing and is poorly is tolerated less well than high flow in patients. And there are some measures that you could look at after a few hours to see whether patients are tolerating that. Lastly, a quick review of the literature on high flow for COVID-19 pneumonia. It is quite interesting that the Cape Town study is still the largest study on this topic. Impressively, you can see that it's been used in patients with mean PF ratios that are very low, less than 100. The average duration of high flow nasal oxygen use is around 3 to 6 days. And patients who do fail or require a ventilation usually do so earlier in the course of their treatment, so they often declare themselves early on. And across the board in these studies, high flow is associated with success, in other words, without the need for intubation, in about 34 to 70% of cases. And in our study, we found about half of patients could be treated with high flow alone and without requiring a referral to ICU. Lastly, the ROCs index at 4 to 6 hours is been shown in a few of these studies to predict the need for escalation of care. And I think although it is the deciding about whether you should intubate somebody really relies on clinical judgment, to be able to put a number, either to follow patients up over time or really to prioritize patients that aren't doing well, can be useful. What about the timing of intubation or whether you should push on with high flow? Well, I think this is something that we're unlikely to see a randomized controlled trial on. What we have to say is that in patients who fail high flow in our setting, we found that their outcomes have been invariably quite poor. And in fact, patients who fail high flow at Kritiske or Tigerberg in our study, only 14% of them survive to discharge. There are a few studies looking at propensity score matching. So this is a statistical method whereby patients are matched for demographics, clinical status, and oxygenation as closely as possible. And these have found that high flow patients proceed less often to intubation. And when they do, they have a higher number of ventilator-free days, and they have a reduced ICU or hospital length of stay in the case of patients that are treated outside of the ICU. So in the few seconds remaining, my summary is that respiratory support outside the ICU has some important equipment considerations. We found high flow to be useful in severe disease and feasible even outside the ICU, and it can avoid intubation in about half of patients, even those with severe alterations in their gas exchange. The threshold for intubation is something that's still going to need clarification, but ROX at 6 hours is an important discriminator of high flow success. And lastly, scaling up this therapy requires monitoring of local capacity for oxygen supply, as well as the reticulation at the bedhead. Thanks, Graham.
Thanks very much, Greg, and for those practical points that are brought up from your experience in managing COVID-19. So we're going to move on now to the issue around patients who require intubation and mechanical ventilation. And firstly, Ross Hoffmeyer, an anesthesiologist at Kritiske, is going to discuss intubation and airway management. Over to you, Ross.
Well, thanks very much, Graham, and thanks for having me. So yeah, I'm going to touch briefly on our experiences and then some of the evidence that's emerging around airway management. And I'm going to try and get through my 97 slides in about 7 minutes. My slides are going to, or my images are going to come up on my video feed, so please make the video feed full screen. My name is Ross. I'm from anesthesia here at UCT, and you're welcome to drop a line to me for any further questions. So really, when this all started, we had to ask ourselves what we knew about airway management in a respiratory pandemic, and many of the people in the field looked at some of the evidence, and particularly this classic systematic review by Tran et al., to ask ourselves, what's going to happen to us when we start doing these so-called aerosol generating procedures and we blow a lot of bugs all over us? Are we all going to get sick, and are we going to die? And in fact, about a year ago, lots of organizations and individuals were coming out with great suggestions, which were effectively best guesses on how we should manage these airways, but best guesses with the science and what we knew at the time. We produced a lot of guidelines, we propagated these, we educated people on them, we modified them for the South African environment, and then we went and we trained on them hard, and we simulated them, and we did in situ simulation in our clinical areas, and we tried to apply them. So what have we learned at Kritiske? Well, we've had two very different patterns through the first and the second wave. During the first wave of the pandemic here at GSH, we had a dedicated intubation team. We had 15 people at a time from anesthesia rotating in and out to provide an intubation service 24 hours a day to go to the wards to these patients who were typically, as Greg's describing, failing HIFNO, go and intubate them safely and transfer them to the ICU, settle them in ICU, and then move on to the next case. In the second wave, because of the lack of a hard lockdown, a lot more pressure on surgical and ICU services, we didn't have that team. We had a limited amount of training and outreach, and many of our physician colleagues were left to fend for themselves on the wards, and we've seen some different patterns emerge. If we look at the data that we have, we can see that the vast majority of our COVID patients who received airway management, particularly in the first wave, were for respiratory failure. And again, typically, once we had the early adoption of HIFNO, this was for failure of high flow. And these patients who were being referred typically had very, very low saturations, the best saturations, despite optimal pre-oxygenation using high flow oxygen, a well-sealing mask, and PEEP, sometimes saturations south of 50, which was definitely not great for patients. We also recognize that despite very proficient, protocolized, swift airway management by a highly trained team, we had profound desaturation and hypoxia of these patients. And they are the quintessential definition of the physiologically difficult airway, a patient who cannot tolerate apnea even for very, very brief periods of time. Interestingly, perhaps because we used quite a skilled team, perhaps because we used almost ubiquitous video laryngoscopy, very good positioning, and this was all protocolized, we had a good laryngoscopy score on almost all of our patients and very few failures of intubation when it was the anesthesia airway team performing intubations, very few airway rescues. Despite this, hypoxemia, as you could see, was exceptionally common, but we also suffered a lot of hypotension and a number of cardiac arrests, about a 1% incidence of cardiac arrest, which for us as anesthetists is obviously a very high figure. We also frequently required inotropes peri-induction, either actually to resuscitate a patient for intubation or during the immediate post-intubation period, and a good number of patients needing inotrope infusions post-intubation on admission to ICU. Interestingly, there has been some more published data from outside of our center, which has looked at this. This is an emergency department study who showed a much larger increase in desaturation around intubation, but no more difficult airways, judging by their first pass success rate. So these patients are frequently as easy for us to intubate from an anatomical perspective, but physiologically exceptionally difficult airways. Interestingly, though, if you look at a very recent publication in JAMA, this is the INTUBE study, which looked at critical care intubations, and this is in the pre-COVID era. This is data from 2018 to 2019. They looked at peri-intubation adverse events and found about a 42% incidence of hypoxemia, cardiovascular instability, 9% hypoxemia, and cardiac arrest in 3.1%. So this goes to show that actually critical intubations, having patients arrest or become hypoxemic or become hypotensive, is actually very common in all critically ill patients and not completely unique to the COVID pandemic. So this is something we should be factoring into our management of critically ill patients, that perhaps dedicated teams and protocolized management is quite useful. We certainly managed a lot of patients with very poor saturations. We tried to do this in a safe manner for the patients and the practitioners as possible. Around this time, there was a lot of data emerging about different ways we could protect practitioners, things like using intubation boxes and barriers. In fact, we looked at some of the evidence around this, and we showed that there was actually no improvement in practitioner protection, but quite a lot of risk for the patient in terms of lower first pass success, more damage to PPE, etc. And also a concerning risk of secondary aerosolization when these devices were removed. There is a light at the end of the tunnel. Perhaps using some kind of barrier devices with built-in suction might be promising, and that might limit viral spread. If we look at overall transmission, the Intubate COVID study looking at practitioners performing intubation showed about a 10 or 11% incidence of practitioner infection. However, if you break this down and compare this to workers in critical care areas like anesthetists and intensivists compared to workers in general ward areas, actually we are very well protected. We might be doing high-risk procedures, but we are actually at a very low risk of infection. And this has led to a lot of thought around the evidence about aerosolized spread of the virus and whether or not we've actually got a law of unintended consequences, that by focusing so much on the AGPs, we're not focusing enough on routine respiratory protection for everybody working in COVID areas. We discussed this a little bit further in some papers that have been published and looking at different levels of PPE, which have clearly been associated with decreasing levels of COVID infection. So there's been a new field of this medical aerobiology, which of course us as anesthetists and airway managers are very interested in. There's some great work which is out there. Wilson publishing this year in anesthesia, looking at an aerosol generation model and showing actually that patients just breathing or coughing or speaking in a ward are probably placing you at more risk than those who are on high flow or non-invasive ventilation. And that when we perform intubations and we have got patients well paralyzed, yes, they do generate coughs and do generate aerosols, but actually it's possibly a lot less than just general use in the ward. So this very nice paper in Lancet making us think about de-emphasizing the risk of aerosol generating procedures and rather thinking of risk as a spectrum for everybody working around COVID patients. Yes, we do need protection, but we should perhaps build this into our systems and have physical illumination and engineering controls rather than too much focus on individuals and their personal protective equipment. So in conclusion, that's my time. What should we be doing? We should be using ubiquitous respiratory protection. We should test our assumptions around what we're doing with airway management, particularly when it comes to introducing new devices into a critically concerning field. And in all of our critically ill patients, especially COVID patients, we must be thinking about anticipating and reducing adverse events. Thanks very much.
Great, thanks, Russ, and thanks for also highlighting the issue of protection of healthcare workers and the fact that, you know, that we need to, you know, watch the evidence as it emerges and adapt our practices around that. So next, we're going to move on to mechanical ventilation, management of patients who require mechanical ventilation. And Jenna Piercy, an intensivist at Groote who's been very involved in looking after patients in our ICU, is going to deal with that. So over to you, Jenna.
Thank you very much, Graham. I feel a little bit cheated by the topic that I've been given, because unlike everything else that's been happening in COVID, there've been huge strides in new developments. And I think invasive mechanical ventilation has somewhat lagged behind. So I haven't got much in terms of new developments and funky, sexy stuff to tell you about. Okay, but I think you can't possibly give a talk on COVID ARDS without mentioning one of the biggest landmark studies that was published in the NEJM back in 2000, which really was it's the so-called ARMOR study that set the way for lung protective ventilatory strategies. And since the ARMOR study, there have been lots more new developments in terms of lung protective ventilation. But again, since COVID hit our ventilator environment in the last 18 months or 15 months, then unfortunately there's been very little new that's come out in the literature since COVID, and with mechanical ventilation in particular. So from the ARMOR study, the lung protective ventilatory strategies were developed, and I think all of you are quite well versed in the data that came out of ARMOR and the recommendations on how we should be ventilating patients with ARDS. And I want to take you now to lung protective ventilation and beyond, because in the last 10 years or so, we've been faced with several different new mechanisms that we can try to implement that will hopefully protect the lungs and stop us from worsening ventilator-induced lung injury and worsening ARDS when we're faced with patients with damaged lungs. And the two that I'd like to highlight and just bring a little bit more of attention to is that the concept of driving pressure and the concept of power. And it's been realized recently that more and more that these are two critical concepts when it comes to lung protective ventilatory strategies. And I do think that in actual fact, these are probably more relevant than the well-described 6 mL per kilo tidal volume limitation that most people seem to be au fait with. So for those of you who aren't aware of what driving pressure is, I've just put a few little equations here. A very elegant study by Marcelo Amato back in 2015 showed quite nicely that driving pressure can be very injurious a high driving pressure is injurious to lungs that are damaged lungs with ARDS, and that we should actually be using driving pressure as a critical target for lung protective ventilatory strategies. So what driving pressure is, it's how the static compliance and tidal volume are related when it comes to the respiratory system. And although that sounds a little bit complicated, at the bedside, it's actually quite easy to work out when you have a patient on invasive mechanical ventilation. So at the bedside, the driving pressure is calculated by the plateau pressure minus the PEEP. And Amato showed that ideally you should aim for driving pressures less than 14 centimeters of water, because above 14 is where you start to get more ventilator-induced lung injury. Now, I think a very important concept is that of mechanical ventilatory power. And I think people have been quite put off by this over the last few years when Gattinoni brought it to our attention, because of the rather complex equation that was needed to work out the power of mechanical ventilation. And what power is the energy delivered by the ventilator. And it's an indicator of ventilator-induced lung injury. Now, some of the newer ventilators actually have built-in software that allow you to be able to calculate the power and display it as a regular parameter on the ventilatory screen. But unfortunately, our ventilators don't do that at the moment. But just a month or so ago on Twitter, Gattinoni and his colleagues have launched this eSmart web calculator that allows us just to easily plug in a few values when it comes to when a patient's on mechanical ventilation to come out with a calculation of power. And what this web calculator is, or the equation is, a composite of that of tidal volume, a variety of airway pressures delivered by mechanical ventilation, and the concept of a high respiratory rate, which is more injurious and gives you a higher power calculation. And I think this is an important concept because by and large, people have kind of ignored a high respiratory rate as causing an enormous amount of ventilator-induced lung injury. And Gattinoni's work has shown that undoubtedly that a high respiratory rate is an important determinant of power. So ideally, we want to aim for mechanical powers of less than 18 joules a minute. Now, just to touch on how we did it when we were faced with our patients requiring mechanical ventilation. Obviously, the first thing to get right is sedation, and most of these patients required analgo sedation with morphine plus propofol infusion. Obviously, you can't continue propofol forever and ever for 2 weeks that the patients were in the ICU, so we had to resort to enteral mechanisms using clonidine and diazepam. If in the first few hours the patient was unable to be managed just by deep sedation alone, then we start a continuous infusion of muscle relaxation. We use cisatracurium as a continuous infusion to reduce the patient's self-induced lung injury and minimize stress and the harmful mechanical power. And hopefully this gives you some anti-inflammatory protective effects. We use cisatracurium, and although the COVID literature suggests that we should be using bolus doses, unfortunately, because of our staffing limitations, we had to use a continuous infusion. We discontinued it as soon as possible, by and large with a PF ratio greater than 150. And then if the patient failed to respond to a neuromuscular blockade, then we instituted early proning with refractory hypoxemia. Patients we found we were fighting a losing battle are those who have a combination of refractory hypoxemia and refractory hypercapnia. And the reason for this is because these two scenarios lead to a mutually incompatible ventilatory strategy. Refractory hypoxemia by and large needs you to either increase the FiO2 or the mean airway pressure, and this is often done by increasing the PEEP. Whereas an acidemia from refractory hypercapnia is usually because of dead space ventilation, and you actually have to increase the minute ventilation and lower the PEEP. So these patients, we actually had to sometimes transfer them onto an ECMO strategy. So just to touch on our experience in a 14-month period, the thing that was unique about our ICU was it was only for patients who underwent invasive mechanical ventilation, who were intubated and ventilated. We had 475 admissions to the COVID ICU, mostly those who failed high flows, Greg Calagaro mentioned earlier. And our all-comer mortality was 64%. And some of these patients actually had diagnoses other than COVID, and the COVID actually was a kind of an innocent bystander. We had 386 patients with confirmed SARS-CoV-2 and ARDS, and our median PF ratio was very low. Of these patients, the mortality rate was 69%, with a median age of 51 years and a length of stay in the ICU of about 11 days. And how we differ from the international literature is there's very little just looking at patients getting invasive mechanical ventilation only. And certainly our PF ratios are substantially lower than those described in the international literature. So what we've learned is lung protective ventilatory strategy at all costs. And I put this in brackets because we've known this all along, but it can be quite challenging to implement in patients with COVID. We've learned in the last few months of the utility of the mechanical power calculation. And during the COVID pandemic, we've been using pressure-based modes of ventilation more commonly than than volume-based modes, because it simplifies the calculations when we're looking at power. We stop the neuromuscular blockade as soon as we possibly can to try to stop the patients from becoming weak. And we've realized that we sometimes still require benzodiazepines despite the controversy in the literature. It may be in the future that we can look to earlier transitioning from high flow nasal oxygen to invasive mechanical ventilation, because our high mortality may be because we're waiting too long before intubating and ventilating the patients. I'd just like to say thank you to all those people in the ICU who've helped look after these patients during these challenging times. And here's a picture of our team, who've been some of the consultants in the team who've been helping to manage the ICU at Critiskia. Thank you.
Great, thanks very much, Jenna, for that overview and really highlighting some of the key learning points from an ICU perspective, and just to really acknowledge the work that you and your team have done in ICU with the dedicated care of the many patients you've looked after, with intensive support, often for weeks and even months, taking care of these people and pulling them through. So we're going to move on now to the issue of palliative care, which is an equally important aspect of the management of patients with COVID-19, those patients who aren't eligible for ICU and need care and support in a different manner. And Renee Kraus, together with her palliative care team, has been attending to these patients' needs. And Renee is going to share their approach from Critiskia.
Thank you, Graham. I think, as you can see from the literature that and the experience that both Dr. Piercy and Caligaro shared, there is a huge need to integrate palliative care in the approach to palliative care, into the approach of COVID. And one of the main things that still remains, two of the main aspects that really need to think of is when integrating or looking at any COVID care, to think about integrating a palliative care approach. And certainly before patients even come to hospitals, those patients who are known as palliative care patients or with complex conditions, that they should have advanced care plans before they enter hospitals. So we know before patients come in that there are already known patients who are going to require palliative care. And this was definitely our experience during the COVID pandemic in the first wave and the second wave, that many of the patients didn't even qualify for high flow oxygen and receiving optimal care and actually did well, but they were known palliative care patients needing their palliative care while in hospitals. And as Dr. Caligaro and Dr. Piercy indicated, there were also patients not doing well on high flow oxygen, not doing well in the wards, and requiring palliative care urgently. We also have to know that when integrating palliative care, it's not just referred to a palliative care team, but that most people can already include the symptom control and the education that patients and families need. One of the main things that really, if I can bring one thing about palliative care that needs to be integrated in COVID care, and that we saw that was really lacking, was communication. And we must know that we are not just dealing with patients, but that we are dealing with families as well. And communication is not easy as an individual or as a junior doctor, but it does require a team to ensure that the team reports back to the family on a regular basis. Our families are facing multiple losses with complex bereavement, and poor communication affects both the patients, the families, and the healthcare workers and the healthcare teams. And we've already seen the mental illness that has, as a consequence of the COVID pandemic, on the healthcare team. Key points that I really want to highlight is make sure the regular communication happens, that it's a structured communication, and that it's documented, especially who you are talking to and who that person is in the family or in as a relative. We've also had to identify patients with family members at risk and also children at risk, and there needs to be quick interaction with community resources to ensure care is integrated in the community to high-risk family members. Family members need to know when next the doctor is going to call. So make sure you already give that family member, we will call you tomorrow, or a number to call. One of the difficulties when communicating and where palliative care communication really comes in is dealing with the uncertainties and to hold uncertainty in a conversation. It's very easy to be the good guy always, but when you need to also ensure that we talk about the worries and our concerns, it does require a skill not to take all hope and compassion, or not to take all hope away, but to compassionately talk about your concerns and your worries. Families found it very distressing when the doctors were saying every day, everything is going well, and the next day the patient passed away. We integrated clinical guidelines, and because there were rotating teams to ensure that the clinical guidelines were available in the wards, and it helped a lot to ensure that equipment like syringe drivers were available in the wards. That made a huge difference in providing medication subcutaneously to patients who were very ill. One of the tragedies around the palliative care pandemic, the palliative care or the COVID pandemic, is that many palliative care drugs have not been available in the wards. And one of the aspects in South Africa at the moment where there's a problem is the availability of haloperidol, which is one of our go-to drugs for delirium and also for managing nausea and vomiting induced opioid-induced nausea and vomiting. We are working to really ensure that these essential medications are available in the wards, And this has not just been in South Africa, but also the World Health Organization is working towards ensuring these medications are available. The medication to contain delirious patients, we really found that it is very distressing for the family, for the patients and the healthcare teams, especially when they try and take oxygen masks off continuously. We must be very vigilant in diagnosing the delirium and ensure that non-pharmacological methods are integrated as soon as possible. Physical restraint, there's good evidence to show that physical restraint actually worsens the delirium and the agitation, and that a low dose haloperidol, if it is available, to start it earlier. Olanzapine also, if it's not available, to start it orally. But when a patient is terminally agitated, to actually integrate a medication like low dose midazolam to try and keep the patient as contained and as dignified as possible towards the end. Shortness of breath, the subjective experience of shortness of breath is very distressing, and a low dose morphine, mist morphine, should be available in all wards to assist the patient just to breathe at ease. This will not decrease your saturation if you are integrating very low dosages of opioids, and if the patient is unable to swallow, please provide it subcutaneously, just a small dosage like 1 milligram that can keep the patient more at ease. If need be, the morphine can then be integrated through a syringe driver to keep the patient just as comfortable as possible. Bereavement, we are still suffering from having to deal with complex bereavement after COVID. It's not easy to say goodbye over the telephone. Families are very isolated. Families are extremely fearful of coming to hospitals, and also having had short funerals and not being together to actually have the bereavement process. The treating team should be available if there's complex questions that arise after the treatment or about what treatment the patient actually received. And many families are facing multiple losses at this time. Families may need facts like how to go about the funeral, who to contact, etc. And there are places where we know that we can refer our children to who are dealing with losses, like PEDSPAL, that is available to offer children bereavement counseling. Please, if you do identify complex bereavement, to do community referrals, and if need be, to refer to further psychological support. But this does need follow-up, and we have found that a weekly follow-up call after a week just to ask the families how they are doing has made a huge difference. As final, I want to say, please make sure you have a planned and positive, purposeful palliative care plan integrated in all COVID responses during this time. Thank you.
Right, thanks very much, Renee, for that succinct overview, and thank you to you and your team for all the work that you've been doing in the wards. Looking after patients, but also empowering other clinicians to implement appropriate palliative care. So we're going to move on to dealing with the cardiac complications of COVID-19. And the next speaker is our head of medicine, Ntobeko Ntuzi, who's also a cardiologist, who's going to address this. So over to you, Ntobeko.
Thanks, Graham, Wendy, and Mark for the invitation. I'm actually giving the lecture on behalf of Biko Nzekhe, who is moderating the specialist exams for cardiology, and the entire cardiac team is involved in those, so they are not able to be part of today's session. On their behalf, I'm going to share some of their experience and important lessons learned from the last 2 waves and incorporate some lessons from the literature as well. Next slide, please. I'm grateful to Biko Nzekhe for having prepared the slides for me. In the height of the first wave, our team in cardiology published a paper in the Cardiovascular Journal of Africa in which they shared some of the 10 key lessons from the first few weeks of the first waves. And in the next few slides, what I'll try to do is to integrate the experience from GSH as well as updated evidence from the literature. I'm going to deliberately not show too much data, but really focus on the key take-home messages. And in today's lecture, there are 3 lessons that I want to share with you. Next slide, please. The first lesson is that don't wait for the rain to prepare the umbrella. This is a Malaysian proverb. And in other words, the planning and reorganization of healthcare services must include advanced preparation and planning for management of cardiac emergencies during COVID-19 surges. And this planning needs to be informed by the knowledge that patients with cardiovascular disease who are co-infected with SARS-CoV-2 are at least 4 to 5 times higher risk of death than those without cardiovascular disease. In addition, COVID-19 patients who develop cardiac emergencies are at significantly higher risk of mortality. Therefore, a clear plan and strategy for the management allows for the best possible outcomes. Next slide, please. The 4 main, if you could advance to the next slide, thank you. So the 4 main emergencies in cardiology related to COVID-19 are 1, decompensated heart failure in patients with pre-existing cardiac disease. 2, acute pulmonary edema in the setting of new onset events. 3, acute coronary syndromes in patients who are at risk of developing coronary artery disease and sequelae. And 4, tachyarrhythmias and bradyarrhythmias, typically atrial fibrillation, ventricular tachycardia, or complete heart block, typically in patients with known structural heart disease. Even though a lot has been written about myocarditis, it's actually rare in COVID-19. And in patients with cardiovascular disease with COVID-19, myocarditis only occurs in less than 5%. However, cardiac injury represented by elevation in serum troponins is quite common, reported in about 30 to 35% of hospitalized patients. And this, importantly, is a marker of COVID-19 disease severity rather than an acute cardiac emergency. And the more severe the disease, the higher the troponin leak. Next slide, please. The second important lesson we wish to share with you is that if you hear hooves, think horses, not zebras. The vast majority of patients presenting with symptoms and signs of acute cardiac syndromes, in other words, acute coronary syndromes, acute cardiac failure, and acute arrhythmias, will have evidence of structural cardiac disease and not an unlikely or rare COVID syndrome. Through a multiplicity of mechanisms, COVID-19, as with other viral illnesses, is a powerful precipitant of acute cardiac syndromes, particularly in those with predisposed cardiac structural disease. Next slide, please. Differentiating between pulmonary edema and COVID-19 pneumonia may be very difficult. Therefore, the clinical context is paramount. For me, the easiest differentiator is to ask yourself, is the patient able to lie flat? Patients with acute pulmonary edema will struggle with the breathlessness when you lie them flat, whereas many patients with COVID-19 can comfortably prone as part of their therapy. In addition, acute pulmonary edema is usually preceded by an acute cardiac insult, usually a new heart attack, tachyarrhythmia, or new onset mitral regurgitation. If there is no evidence of such an insult, then COVID-19 is much more likely. Further, pulmonary congestion and COVID-19 pneumonia may occur concurrently in patients with advanced structural disease. Next slide, please. The third and final lesson we wish to share with you is that treatment deferred is treatment denied. We know that the outcomes of most acute cardiac syndromes are time dependent. Therefore, delaying treatment of cardiac emergencies while waiting either for SARS-CoV-2 results or because patients have been diagnosed with COVID-19 uniformly leads to poor outcomes. Next slide, please. In this publication in the Journal of the American College of Cardiology, comparing North American cohorts acquired pre-pandemic and those in blue from the COVID-19 pandemic, you will note that in the top panel, the effect of delaying treatment represented in those with STEMIs, either as time of symptom to admission or time of door to balloon, was much higher in those with COVID-19 compared to matched pre-pandemic cohorts. Similarly, in patients with non-ST elevation MI, the time to admission was also much longer. And the consequence of this deferred treatment was that complications, including cardiogenic shock, as well as in-hospital mortality, was much higher both in patients with ST elevation MI as well as non-ST elevation MI. Similar observations have been made for patients presenting acutely with heart failure. Next slide, please. Therefore, to conclude, we wish to also remind you that, next slide, please. COVID-19 is not a contraindication to life-saving cardiac procedures, and patients with complete heart block or any other related rhythm disorder should be referred for permanent pacemaking or other interventions. In addition, patients that need rescue PCI or a pharmacoinvasive PCI after thrombolytics for acute MI should be referred as per usual, and there is absolutely no reason to defer referral of these patients. I wish to end there, and we look forward to taking your questions. Thank you.
Great, thanks, Ntobeko, for highlighting those key points and for stepping in for Pico. And just to acknowledge, to say thank you for your supportive and steady leadership of the department and the COVID response at Grooterschuur throughout the pandemic. So to move on to our final input is on the key issue of diabetes. Diabetes is incredibly common, as I'm sure Joel will highlight, among patients who require admission to hospital with COVID-19. And the appropriate management of those patients is a key aspect of COVID-19 management. So Joel Dave, who's head of endocrinology at UCT, is going to present on this.
Thank you very much, Graham, and also thanks to Mark and Wendy for the invitation. So South Africa has about 4.6 million people living with diabetes. So it was inevitable that these two pandemics were going to clash. And very early in our pandemic, we read reports from the Northern Hemisphere showing that people living with diabetes were at much greater risk for worse COVID-19. But also in those reports, age was an independent predictor of worse COVID. And if you have a look at the population pyramid of South Africa, you can see that we're quite a young population with only about 15% of our population over the age of 50. And if you contrast this to the countries that experience the worst mortality in people living with diabetes, here you can see the UK, the USA, and Italy, you can see a completely different shape with a much older population and with about 20% or 25% of their population over 50. So it was hoped that our people living with diabetes would have a different outcome. However, this was not to be the case. And very early in our pandemic, in about June, the Western Cape comorbidity report showed that indeed people living with diabetes were at much greater risk of mortality than those without comorbidity. And in a study that we've just submitted for review and hopefully publication, looking at all patients in the first wave, diagnosed with COVID-19 up to the 31st of July 2020. Indeed, again, it was shown that diabetes was an independent predictor for hospital admission and mortality in people diagnosed with COVID-19. And you can see that of the 65,000, there were about 14% that were diabetes. And this is sort of similar to the background prevalence of diabetes in the Western Cape. And so people living with diabetes didn't seem to be at greater risk of getting COVID. However, you can see that once they were diagnosed with COVID, almost half of them, 45% required admission, and there was a 15.4% mortality, much greater than those that weren't diagnosed with diabetes, and also a fourfold increase in admission to the intensive care unit. Interestingly, once admitted to hospital, the pre-admission HbA1c was actually not a predictor of mortality or a more severe course once admitted to hospital. There is data and reports suggesting that metformin might actually be protective. However, there is conflicting data. But if you look at it overall, and most of the studies being observational studies, there is a trend towards actually showing a reduction in mortality. And if we have a look at our data, we mimic this with metformin. See down over here, actually seems to be protective of mortality once people living with diabetes are admitted to hospital. Great debate about whether the control of diabetes changes outcome. This was a very early study published from China, showing that if you actually manage to control the diabetes of your patients, you altered their mortality, you improved mortality with controlled diabetes. However, since then, there's actually been no robust data. There's no advice on regimens that should be used, and there's no advice on targets that would be most beneficial for achieving outcomes. So if we then look at the challenges that we face in managing people living with diabetes who are diagnosed with COVID-19, and especially those that are admitted to hospital, well, we have healthcare workers from a variety of disciplines working in the wards that aren't experienced in treating patients with diabetes. There's staff shortages, making intensive regimens inaccessible. There's a variable clinical status of our patients. Steroids are widely used. Because patients are ill, they are having irregular meals. There was an increase in the prevalence of new cases of diabetes. And many of these patients during the ward were isolated, so there was not access to the multidisciplinary team that usually takes care of patients living with diabetes, especially diabetes educators. And then also once discharged, these patients are having to self-isolate and manage themselves. So what are then some of the principles of in-hospital treatment? Well, I think clearly defined simple protocols would be ideal, so that there's consistency of care, and also to guide those that don't really have experience in managing people living with diabetes. At Groote Schuur, we designed a clear protocol for pre-existing diabetes, for new onset diabetes, and for those that are admitted with diabetic ketoacidosis. Individualized glycemic targets would be ideal. The whole paradigm of treating diabetes has changed to individualized regimens and individualized targets. And I think especially in the setting of COVID-19, where there's wide clinical spectrum of presentation, individualized targets are paramount. Very important to try and select the simplest treatment regimen to achieve glycemic targets. And this must be realistic for the facility. There's a widespread disparity between technology available and staff available at all the different facilities that manage COVID-19. But probably if one can, the best would be to use an insulin regimen if possible. regular monitoring of finger prick glucose readings and adjustment of insulin doses. And if there's no contraindication, perhaps because of the emerging data, try to keep the patient on metformin. So then I'll end off with just some specifics of ideal in-hospital treatment. There's no doubt that people living with type 1 diabetes who are admitted, they should continue on a basal bolus regimen with monitoring of glucose before each meal and adjustment of insulin doses. With those with type 2 diabetes on steroids, they should have a BD long-acting regimen, in this case with Protophane, with correction doses of Actrapid at meals. This is ideal and would have to be tailored according to the facility where the patient is. If the patient is not on steroids with mild disease, then you can continue with a simple oral regimen or an insulin regimen to achieve the glycemic target. And in patients with severe disease that aren't on steroids, then the simplest insulin regimen to achieve glycemic control should be used. So if the patient is on oral treatment, this should be stopped and the patient should be started on an insulin regimen. And the glycemic target should be about 8. Somewhere between 5 and 10 is fine, but it's essential to avoid hypoglycemia and hyperglycemia because both of them in their own right have been associated with in-hospital morbidity and mortality. So with that, thank you very much for listening.
Great. Thanks very much, Joel, for highlighting those key points. And then thanks for all that you've done in developing materials and tools for the management of diabetic patients in our wards. And just to highlight to colleagues from other hospitals that that material, I'm sure that if people wanted to get access to that, they could contact Joel and we'll certainly try and make it available on our department website as well. Unfortunately, we have run over by a bit and we've taken the decision not to take questions today in the interests of time. So it just sort of remains me to say thank you, a big thank you to all 8 of the speakers that have really given us excellent talks, highlighting key issues of management based on practical experience within the healthcare service, but also bringing in what has been learned internationally and has been published in the literature. So with that, to say goodbye and to hand back to Wendy and Mark.
Thanks everyone for this really wonderful webinar that we've had, very good attendance, and unfortunately we couldn't actually take the questions, but I think feel free to actually email the individual speakers with any burning questions that you might have. We'll see you again next month.
Goodbye, thank you.